Good afternoon, everyone, and welcome to the OrthoVirginia Facebook Live. My name is Dr. Ryan Barnes, and I am a sports medicine subspecialty physician, part of OrthoVirginia. I practice in the Richmond area, specifically at the Prince George office location. And today we'll be talking about something that I talk about. A lot of patients see a lot of this, and this is shoulder arthritis. So today we'll be going through everything that you need to know about a shoulder replacement. I have no financial disclosures. So what is shoulder arthritis? So essentially, shoulder arthritis is the loss of cartilage lining of the ball and the socket joint of the shoulder. Cartilage is essentially a lubrication, a softening between the two bones that help the joints and the bones move smoothly. And when this wears down, this leads to arthritis. In the same way that you can get arthritis in the hips, in the knees, you can also get it in the shoulders. And this causes patients to have pain, decreased motion, stiffness, and some people will complain about mechanical symptoms, so grinding, popping as they move the shoulder. So the picture on the right shows the humerus, which is that ball side, and you can see there's some decreased space between the ball and the socket, which is called the glenoid. And as we're tracing out here, that kind of shows this bone spur that is formed as a reaction of some of the arthritis. So what are some of the basic treatments for shoulder arthritis? I think it's really important to give patients kind of a full range of treatments ranging from non-operative to operative. And I really try and exhaust all non-operative treatments for patients before we talk about the last option, which is always surgery. I think the first and most obvious thing is kind of observation or continued non-operative management. This is essentially saying, we know you have some arthritis of the shoulder. We know it can kind of cause some of these problems, but if it's not bothering you too much at this point, we can kind of keep an eye on it and kind of just monitor your symptoms. Physical therapy or home exercises are sometimes something that can be considered for treatments. As the arthritis tends to progress and that bone on bone becomes a little bit more severe or advanced, maybe some of the benefits of exercise and motion might become a little bit less impactful, but I think it is something that you can try and do. Medications is something else that you can try, specifically anti-inflammatories, over-the-counter or prescription medications, over-the-counter being ibuprofen. Prescription anti-inflammatories are also an option. In some instances, some patients are not able to take anti-inflammatories if they have heart or kidney disease or if they're on anticoagulation. But the anti-inflammatory medications are usually some of my go-to medications to try and help with some of the symptoms that come from arthritis. Another option that I frequently will suggest to patients to try if they're not quite ready for surgery is a steroid injection. A steroid injection, in the same way that a medication is anti-inflammatory, it has steroid in it that also has anti-inflammatory properties. You inject it into the shoulder joint, and this kind of helps to calm down some of the inflammation, can give some pain relief. Now, injections don't necessarily treat or help with some of the cartilage loss. That's kind of more of a progressive disease that will, over time, tend to get worse. But for a lot of people, it does give pain relief. And for those people that are not quite ready to pull the trigger on any type of surgery or treatment, it can be a pretty good option for those people. And then really, if we've kind of exhausted all those options, we've tried exercises, medications, injections, and the pain is still debilitating, the last option for me is always surgery. And surgery, I tell people, is really kind of more of a quality of life type of decision. It's if you live with this pain day in and day out and you feel like you no longer can really live with it, I think trying a surgery is a reasonable option to hopefully kind of help with some of your symptoms. So what do I tell patients are the goals of surgery? The thing that I always tell people, that the most reliable thing that we can do with a shoulder replacement is pain relief. Essentially what you do with the surgery, and we'll go through this in a couple slides, is you kind of remove some of that arthritis, you do the shoulder replacement, and that gets away that arthritic bone, that bone on bone contact that causes the pain. So pain relief is the thing that we can most reliably improve with the surgery. Now, a lot of people ask about, will my motion be the same? Will my motion be worse? How will my strength be of the shoulder? Motion tends to be a little bit less reliable in terms of a result that a patient will get after surgery. And it can really depend on the type of motion that a patient has before the surgery. As I mentioned earlier, as the arthritis tends to progress and becomes more severe bone on bone, your motion can become a little bit more, there can be a little bit more stiff with the motion with the shoulder. So potentially getting that motion back after a surgery can be more challenging. But I always tell people that the thing that we can most reliably guarantee and help with the most is pain. So something that I get asked about a lot are the different types of shoulder replacements, and there are kind of two main categories. There's what we call an anatomic total shoulder replacement or reverse total shoulder replacement. Now, essentially, the two difference between these two is whether or not the rotator cuff is functioning. The rotator cuff is essentially the muscles and tendons around the shoulder that gives some stability to the shoulder, allows you to move the shoulder, gives you strength. If the rotator cuff is intact, we usually will try to do what's called an anatomic total shoulder, which, as you can see on the image on the far left, you replace the ball or the humeral head with a ball and potentially a little stem that goes down the bone. And you replace the socket side or the glenoid with a little plastic liner. Now, if the rotator cuff is not functioning, that can lead to changes in the alignment of the shoulder and can lead to what's called rotator cuff arthropathy, which is essentially a different type of shoulder arthritis. Because you don't have the rotator cuff functioning as properly, it's not going to be working properly, which you need it to be for the anatomic total shoulder. And so the reverse is another muscle, mainly the deltoid, and you replace the ball side of the shoulder with socket, as you can see on the far right, and you replace the socket side of the shoulder with the ball. So you're essentially almost like swapping the pieces. So that's why it's kind of called a reverse. So you can see the picture on the right compared to the left. The ball is now on the other side, and kind of the socket side is what the portion that goes on the humeral side and down the stem. So if you come to clinic and we've kind of talked about options, kind of exhausted some of those other treatment options, we talk about planning for surgery. Preoperatively, I typically will get a CT scan for surgery, and essentially what this allows me to do is to do the surgery in a computer before we even do it at the OR. And I think this gives a couple of really good benefits for me and for the team in the day of the surgery. It allows us to look specifically at your bone. It allows us to then determine which pieces we think we are going to most likely use. And essentially allows me to have kind of this cross-reference point, day of surgery, say, this is kind of what we thought we were going to use. Are we seeing something different? It allows me to kind of go back and check that. So it allows me a good kind of tool of reference to use in the operating room. And also through the software, you can kind of create a guide, which I've kind of included a couple pictures in the bottom right-hand part of the screen, a guide that you can use during the surgery, actually, that's based off of your CT scan. So we're using that guide during the surgery to kind of give us a more accurate trajectory and aiming tool in the OR. And really, I think the other thing to always talk about that's important is making sure that surgery is safe. So we've kind of talked about the shoulder, but obviously everyone has various medical issues or conditions that might need to be addressed before surgery. So getting medical clearance from a primary care physician or whoever you see that manages your primary care medications, making sure it's safe to have surgery. So surgery is done. What's next? I think typically for my total shoulders, if patients are doing well and pain is well controlled, they can go home same day. If pain is not well controlled, usually spend the night for one night. So now they've left the hospital. Physical therapy is an important component to the surgery. I think it's important to kind of give patients a good idea of what that looks like, because there is going to be a little bit of buy-in after surgery in terms of working with therapy and working on your motion and strength. So I tell patients physical therapy up to 3 or 4 months, and that's really to avoid stiffness, get the motion back, get the strength back. Wearing a sling, most patients will be wearing a sling following the operating room. That's roughly 4 to 6 weeks following surgery while some of the soft tissues recover and kind of some of that early healing takes place. Returning to activity, I think, really depends on your goals. Some people want to get out and do some things that are maybe a little bit more active than others. I usually tell people returning to activities of 3 to 4 months. For example, a lot of golfers, I tell people to kind of start with short game, like putting, chipping before they're going out and trying to hit their driver 330 yards. So really just trying to gradually increase your activities. And all that kind of depends too on how they're progressing individually with physical therapy. So not everyone always progresses at the same rate. There's a little bit of a range and kind of gap in how people are recovering and what they want to get back to. So I think that's most of the slides that I had prepared. Thank you all for your attention. I'm happy to answer any questions that might be coming in through the chat.
Thank you so much. Yes, if you want to leave your questions in the chat, we will take a look at them. We also had some questions come in earlier. So how long after a shoulder replacement or a reverse shoulder replacement does it take before someone is clear to drive?
That's a good question. So kind of my typical spiel for driving is I tell patients they have to be off of narcotics for 24 hours. Pain medications can cause patients to be drowsy. So I usually say you have to be off that for 24 hours. While patients are wearing a sling, I usually advise against driving. So that's usually that 4 to 6 week period. However, there are a lot of patients that may go back to driving with the sling on. I usually tell people to go out and almost pretend like it's driving again for the first time. You got your learner's permit, you go out to a big parking lot where you can kind of almost go back to learning the basics again, making sure it's safe for you, not only safe for you, but also for, other people that are driving out on the roads. I always think kind of worst case scenario, if there's an accident or you have to react in some emergency situation and quickly move, the last thing I'd want to do is you to be limited by your arm, by your shoulder, by pain. So I think going out and kind of testing the arm and your comfort level while you're driving is really important before kind of getting back out on the road.
Thank you. What are limitations after surgery? For example, will you be able to throw a baseball, lift weights, that kind of thing?
Yeah, that's another good question. So limitations really for the first 4 to 6 weeks while some of the soft tissues heal in, because we actually have to go through one of the front rotator cuff muscles as we go through surgery. So that usually takes first 4 to 6 to 3 months really to kind of heal in. And we kind of talk about some restrictions with shoulder movement, kind of internal rotation, pushing up off a chair. A lot of the literature shows that limiting how much weight you lift with your shoulder after shoulder placement is usually good. So less than 25 pounds of weightlifting with the shoulder. A lot of patients will go back and do the activity that they really would like to do. That's usually what I will quote to patients, is to try and limit weightlifting to less than 25 pounds for the future after shoulder replacement. And really kind of the thought process behind that is in the same way that, people will say that hip and knee replacements like last 20 years, the same thing can happen really with a shoulder replacement, and a shoulder sees less stress than a hip and knee because you're not really walking on your arm. So you're not really seeing a lot of that force going through the shoulder joint. But there is that plastic lining that can wear down theoretically. So I do try and tell people just to be fairly smart about the choices that they make and the activities that they do with the shoulder. But obviously one of our goals with the surgery is getting people back to the activities that they want to do.
Thank you. Is there any difference in recovery time between an anatomic and a reverse shoulder replacement?
Really, for my protocol, the rehab is essentially the same. In the anatomic replacement, because it relies on the rotator cuff and some of the healing being a little bit more important, I try and maybe be a little bit slower with some of the recovery, potentially depending on how the surgery is with the reverse. I try and repair some of the tissue just to kind of give it some more reinforcement. If we're unable to, due to some of the tension during the surgery, then potentially rehab can be a little bit faster. But I usually just try and, as like a fairly standard rule, have my protocols be roughly the same.
Thank you. After it's healed, will a shoulder with a reverse replacement look different than one that hasn't been replaced, or with an anatomic replacement? Yeah,
so that is a good question. I would say potentially for a reverse total shoulder, which requires a lot of, we check in the operating room, the tension. One of the, we always talk about risks and benefits of surgery. One of the risks with any type of shoulder replacement that you do is it can potentially dislocate or pop out a joint where the ball and the socket come out of place. That can happen with a normal shoulder. It can happen with an artificial shoulder. So potentially, like in the operating room, as we're checking that and we're checking the stability, and if we have to make it a little bit tighter, it might make the shoulder look a little bit different just because it has to be a little bit tighter. Most people, I would say, don't notice a difference, but it kind of depends a little bit on your body habitus. People that are a little bit more frail or a little bit thinner might notice it a little bit more than other people. But I'd say that's a possibility, but not something that I get mentioned from patients too often.
Thank you. If someone needs to have their shoulder replaced for both shoulders, how long between the two surgeries?
Yeah, that's a good question. I usually say about 3 to 4 months. I think it's important to make sure you have enough time to rehab the first one. People have bilateral shoulder arthritis, which is not uncommon. Usually talk about doing the one that bothers them the most, or some people like to kind of do the dominant shoulder first, just so that way they have that for the other recovery. But I usually quote about 3 to 4 months in between the two.
Thank you. If somebody lives by themselves, will they need somebody in to help them as they're recovering from surgery? or are they able to be independent right away?
Yeah, that's also a really good question. I think that's always really important to talk about with your surgeon before is, your social situation, who you live with, what type of help you might be able to have after surgery. I think it's always helpful to have someone at home with you, at least for like that first week or two, to make sure you're doing okay. Now, there are certainly people that do it without that, but it's hard to really understand maybe what it's like living with your arm in a sling for that period of time without a whole lot of use in it. And you're basically relying on one shoulder, where it can be a lot more limiting than people I think probably realize before surgery. So it's really nice, and especially if like people are having a lot of pain or a lot of people have nausea after surgery, it might be really helpful to have someone around the house that can maybe help take care, whether that's for the first few days or maybe even a little bit longer. I think it's really important to talk to your surgeon before surgery about that to make sure you have a good plan in place for after surgery.
Thank you. Does insurance pay for both types of shoulder replacement?
Yeah, it's a good question too. So I'd say that most insurances will pay for it as long as it's covered, and there's not really a whole lot of difference from our end in terms of billing between the two. So it's not really that much of a difference from our side in terms of the billing or like the coding of the surgery. It's actually the same. It just kind of depends on what has led to the various causes of the arthritis of the shoulder.
Thank you. Will the replacement be heavier than the original shoulder?
I don't think anyone's ever asked me that question. So during the surgery, you do have to cut away and remove some of the bone. I know I briefly talked about that. The implants typically are pretty small and pretty lightweight. I would say that it might weigh slightly more. I don't know the exact numbers, but I imagine it's probably going to be pretty comparable to what a normal shoulder would feel and weigh like. I know some people say after hip and knee replacements or even shoulder replacements, that doesn't maybe totally feel like the normal knee, the normal shoulder, but I've never heard weight specifically referenced, so I'm not entirely sure. Maybe I'll have to ask some other patients to see what their thoughts are.
Thank you. If someone has an anatomic shoulder replacement, which uses the rotator cuff, and then later they tear their rotator cuff, would they then get a reverse replacement?
Yeah, that's a great question. So a lot of insight with that question. So yes. So because the anatomic total shoulder relies on the rotator cuff, and then if the rotator cuff were to fail, that could lead to a similar type of arthritis as to someone that has the rotator cuff not functioning to begin with. And so essentially that would lead to some changes in the shoulder. It might lead to that anatomic total shoulder failing and potentially needing to be revised to a reverse total shoulder. Now, I will also say that, we always talk about this with risk and benefits of surgery, that is one of the risks potentially with an anatomic. You might need revisions of any type of surgery that you have. So that is a known risk. And I think it's always important to kind of talk about those obviously things in a little bit more detail before surgery, but that certainly could happen. Yes.
Thank you. How can someone prepare for a shoulder replacement? Are there exercises to do ahead of time?
So I usually tell people that, in my mind, the stronger you can go into a surgery, the stronger you come out of it. As I kind of mentioned in, I think, kind of like my treatment slide that we talked about, where you talk about observation, exercises, things like that. Some people struggle with exercises or physical therapy just because the shoulder arthritis is already so advanced that their motion is limited. So some people, it can be really hard to really strengthen or exercise the shoulder before surgery. But I usually just tell people the natural course of shoulder arthritis is to progress with time. It tends to get more worse, but the stronger you can go in, the stronger you usually can come out of it. And, I really think that's important to still use your shoulder as much as possible through daily life. It keeps kind of the motion up. It can improve some of your strength. So I usually like to give patients some exercises to do if we see in clinic, no matter what, just because I think if you can get some of the strength up ahead of time, it can only be beneficial.
Thank you. Does a previous rotator cuff surgery impact the outcome of a shoulder replacement?
Yeah, that's a good question too, and something that we see a lot. Rotator cuff surgery is another surgery that I do that, just like any other surgery, it can fail, it can wear away with time. Typically, for patients that have had previous rotator cuff surgery, I feel like the choices between anatomic and reverse, I tend to lead a little bit more towards a reverse replacement just because you go under the assumption that maybe the rotator cuff surgery has failed, but that's not always the case. When we're in the surgery, we look directly at the rotator cuff, determine if it looks healthy, determine if the surgery would be potentially could be an anatomic replacement or would need the reverse. That having a rotator cuff repair, a lot of times you use anchors during those surgeries, and you might encounter those during the surgeries. You just take them out, and they don't really cause too much trouble or difficulty during the shoulder replacement itself.
Thank you. Are there any restrictions on how you sleep after a replacement?
Yeah, so I usually tell people that the best way to sleep for especially those like first 2 to 4 weeks or maybe a little bit longer is in a recliner. A lot of people with shoulder pain, regardless of what it is, if it's from arthritis, if it's from rotator cuff biceps, a lot of people complain about pain at nighttime. I think it's just kind of like where you finally settle in a bed, whether you're a side sleeper, back sleeper, it just puts a little bit more maybe strain on your shoulder, or maybe you're just laying down and you're finally starting to notice some of this pain. But the majority of people that I see that complain of shoulder pain have a lot of pain at night. So normally I recommend people to try sleeping in recliners. It might protect the shoulder a little bit more, so not laying on it. They're not going to roll over it during the nighttime. So I usually will tell people to maybe try and sleep in a recliner for those first few weeks after surgery. I think it usually helps them out a little bit.
Thank you. Are shoulder replacements a treatment for chronic dislocation?
That is another good question. That might be a little bit out of the scope of this talk, but totally depends on the patient and the pathology. There are a lot of different treatments for shoulder dislocations that can range from arthroscopic or kind of just like a scope treatment to potentially needing like a bony block or transfer. Sometimes down the road, if you have continued instability, a total shoulder might be an option, but that would totally need to be like a patient by patient case and something I would definitely have a good discussion with your surgeon about. Thank you.
How large is the incision, and are shoulder replacements considered to be minimally invasive surgeries?
I would probably not call it minimally invasive. It's an open surgery, and normally the incision kind of runs down the front of the shoulder, starting up around, I don't know if you can see it, probably around here, and it kind of goes a little bit around the armpit area. So incisions are probably about 6-7 centimeter incision. And so we have to go through the front of the shoulder to get into the shoulder joint to do the surgery. So I usually tell people it's an open surgery. I try and make it as small as possible, but also want to make sure we can see everything so that we do an adequate job and give you the best result possible.
Thank you. Are there any age restrictions, either upper or lower, on having a shoulder replacement?
Yeah, so I usually tell people, and this kind of gets back to a little bit of the management, where I think everyone's directions of how they want to proceed with various treatment options, how aggressive they want to be, depends a little bit on their goals, their age. I usually try and tell people that ideally, you have one replacement and you're done. The literature is still kind of out a little bit with some of the shoulder replacements, but most papers out there are quoting pretty 20, 30 years for a shoulder replacement. But that can be a little bit on a case-by-case basis. So I usually tell people that I want to do one, don't want to have to do a second one because the second one's always harder. So I usually try and tell people to live with it as long as they can until they feel like they can't live with it anymore, and that's when we do surgery. So if you're really young, we try and hold off as long as possible. Now, in terms of the upper end of the spectrum, it depends a little bit on the patient. I usually tell people that age is just a number. Some people can be 80 years old, but are still out there being really active and maybe acting more like a 60-year-old. So in those type of people, if they potentially have a lot longer to live, then it can give them a long pain relief for a lot of years, and that can be really helpful. So I try not to look at just an age number, and then you have to look really at the whole picture of a patient to see whether or not it'd be a good decision for them.
Thank you. Do shoulder replacements have an impact on the muscles in the rest of the arm?
Yeah, so depending on the type of replacement, so in a reverse, where the rotator cuff is not really functioning properly, it actually recruits other muscles that can help out get your shoulder motion back. So a lot of people sometimes say that it feels a little bit different, and that's mainly because it's using some different muscles and areas of the shoulder to kind of help get your motion and strength back. That's why physical therapy can be so important. to get the motion and the strength back in the shoulder. So it can impact a little bit some of the other muscles around the shoulder for sure.
Thank you. Are there any exercises that somebody does while they still have the sling on, or are they just in the sling the entire time and they don't start any PT until afterward?
No, I like to start physical therapy fairly quickly, usually within the first 2-week mark. So the sling is really, I think, a couple of functions. One, it's to keep the arm from moving too much. So getting in therapy, usually starting some gentle motion. If you end up staying the night in the hospital, I usually love for physical therapy to come by even that first day after surgery, just to get you out the sling, make you feel a little more comfortable, kind of give you some basic exercises to do so the shoulder doesn't get too stiff. I usually like people to come out of the sling with therapy. And as you work with therapy, they can give you some exercises to do at home to kind of work on some gentle range of motion of the shoulder so it doesn't get too stiff. So certainly not locked in the sling for those first 6 weeks once you move in it a little bit. And that depends a little bit on how you're progressing with physical therapy.
Thank you. How many steroid injections can you have before you have a replacement?
So some people don't want any injections and they just say, well, I view it more as like a Band-Aid and not necessarily a long-term treatment. So some people don't really want to have any injections. I think that's a fine route to take. Some people say, well, I want to try the injections, exhaust all the options before we move forward for surgery. I think that's also a reasonable option. At some point, you'll probably hear different things from different people. Some people say 3 injections versus there's some people who just say, I never want to have surgery. I never want to have a shoulder replacement. And if the injections give you 3 months relief, then they just want to do injections for the rest of their life. Steroids can eventually cause a little bit breakdown of some of the tissues. And so I think it's important to kind of take that a little bit of case-by-case basis, kind of where you're at in the process, if at all you're considering a surgery. I usually tell people, again, that the shoulder replacement's a quality of life and it's not necessarily a surgery that you urgently have to have. There are some scenarios where I usually like to keep tabs on people like every 3 to 6 months, get x-rays, make sure it's not progressing too rapidly. There are some instances and we might be a little bit more aggressive and I might push you towards surgery a little bit more, mainly because if the arthritis gets really severe, it can change how the ball and the socket are wearing each other and cause a little bit more erosion or wearing away of some of the bone, which could make surgery a little bit more challenging or difficult. So if we start to see some of those changes on an x-ray, it might be an indication that the arthritis is progressing a little bit faster. So that's why I like to see patients back every 3-6 months, maybe get some new x-rays, make sure there haven't been significant changes so we can kind of keep going down the same treatment route that we've been going down.
Thank you so much, Dr. Barnes. That is all the time that we have for today. Would you like to close?
No, I just want to thank everyone for attending. Obviously, if you have any questions or concerns, feel free to visit our website, www.orthovirginia.com, and just talk with your surgeon about your shoulder, as everyone really has pretty unique needs and I think goals. So it really is a case-by-case basis, but hopefully this has been informative and beneficial. So thank you all for your time.